I'll just state.
Okay.
So, hi everyone, my name is Mayank Kalyani. I'm one of the National Officers of Artery Dandy Neurosurgical Students Club India. So today we have here Dr. Sampath Ramachandran. He's a highly experienced radiologist in Detroit, Michigan, and is affiliated with multiple hospitals in that area. And he received his medical degree from University of Minnesota Medical School and has been in practice between 11 to 20 years. Today, he'll be disclosing with us about the secrets of brain CTs and their interpretation. And I hope this really helps you in your current academic position and your upcoming internship and so forth and so forth. So I hope you'll enjoy a lot about this talk. So yes, sir, you can start.
Thank you for the time, for actually giving me this opportunity to be able to actually talk to you guys today. So basically, I will try to make it as easy as possible. I want to give you, first of all, a brief description of the basic anatomy. I'm pretty sure some of you must have seen a lot of this basic anatomy of the brain, and then take you from there to how we look through the lens of a CT, and then what kind of applications we use the CT for in terms of imaging pathology and some of the cases we see typically in the ER and beyond. I'm actually a ER radiologist, so I see a lot of cases that we see in basically in an acute setting like traumas and strokes, and that would be my biggest chunk of cases. But we do see other types of cases too, where it's more of a chronic problem in terms of the neurologic symptoms. So basically, let me give you a brief description of what CT is like. Let me quickly switch over to this screen here, which gives you a basic understanding what CT actually does. So imaging itself, you can just, I don't want you to go through this description here of what a CT does, but I just wanted to give a brief description of a CT scanner looks like. I'm pretty sure some of you must have already seen this in the past. And then we go through, when a CT is actually performed, they slice it in, typically we see it in the axial plane. So actually, as you can see, it's sliced in the axial plane through the head, and then it's actually presented to us in this type of image. And then we can see it in either brain window, which is what we see here, or in skull, or in actually in bone window, which actually shows us all the basically the calvaryal structures and gives a better basically better understanding of how the bone looks like, you know. So this is a brief. So let me get to the next few slides, which is basically talks about the risk of CT. Of course, you all know about radiation being a risk of CT, but effectively, the radiation is not a big problem as long as we really understand how to use it. And so we need to be careful when we use these kind of techniques to use it more appropriately and not to use it on whoever comes to the door. But still, you know, unfortunately, ER is a place where a lot of these things are difficult to control. So people don't exactly use all the best practices, but still we try our best to do that. So basically, when you look at a CT, let me go through this terminology they have to talk about. They talk about hypodense, which is compared to the rest of the brain, which is here. There's actually less density. That's why we call it hypodense. And isodense this is actually the CSF, which is the cerebrospinal fluid here. So this is similar to that. So that's why we call it as isodense. And then we call it hyperdense, which is more higher in density than compared to the rest of the brain. So that gives you a brief understanding of what the terminology we use in CT. And we also talk about basically attenuation, which is the same way of talking about basically hyperdense and the same terminology in a different format. So that's what we do here. So let me switch out here and go quickly back to anatomy here, just give you a brief description of it, that you have some understanding as to what I'm speaking about. And so here we are just taking a quick look at the brain anatomy. So we have the frontal lobe here and the parietal lobe, occipital lobe, temporal lobe. This is the cerebellum. This is the brainstem. So this is a very brief description of the basic brain. Here we are looking at basically at the sagittal plane. So we are seeing the images, but then of course we will switch over to the axial plane once we get to the CT part of it. And this gives you a brief understanding of how the skull looks like in the CT. And you can see the colored portions. You can see the parietal bone here, and then the frontal bone. Let me get to this one here. And then you can understand where, and then this is the occipital bone, the back, parietal bone, frontal bone. So these are different slices of a CT through which we can see different parts of the skull and really understand what each of them is called. And so I don't want to spend too much time on this because I think it's too much information. So I will just try to be as brief as I can with this. So this is, we are looking at the temporal bone here and then looking at the sphenoid bone here. So this sort of gives you a general, I guess, general idea that we can get a lot of information from the CT in terms of anatomy and also to understand as to what we can see through this. So let me switch out of this one and let me quickly run to this part where we see how to read the CT. So if you have any, if I'm actually going too fast, please let me know, because I don't know if I happen to go too fast and if it's kind of hard for you guys to keep up.
Sure.
Let me know. I'll actually slow down a bit. Okay, I'm okay with my speed now.
Yes, sir.
Okay.
Yeah, perfectly.
All right. So here, here in this case, here's the CT of the brain. Let me square it out a bit. So this one actually kind of as I scroll through it, you can see how the different parts of the brain are actually labeled. So here I'm actually going to start from the very bottom of at the base of the brain. So we see part of the spinal cord here in the very center of the, we call this as the foramen magnum, which is the biggest opening in the skull here at the base of the brain. We call it the foramen magnum. So you can see part of the spinal cord here. And as we go up, you can see various structures come into view. And these are all this is cerebellum nervous system. We don't actually use all this terminology at all times. And you can see some of the vascular structures. You can see the right and left vertebral artery. These are very hard to see in some CTs because again, it depends upon technical factors. Sometimes we can see, sometimes we don't. So I just want to give you a general feel for the kind of things you can see in a CT of the head just briefly. So this is the cerebellum. So we briefly saw a picture initially, and then now you can actually see on CT. And if you can imagine, we are doing this in the axial plane. So you have to imagine going down the brain in form of slices. That's what we're doing essentially here. And you can see different parts coming into view. This is the medulla here, which is the part of the brainstem. And then as we go up, you can see more of the cerebellum, and you can see more of the vascular structures here. You can see the vertebral arteries. That's what is being shown here. And then as we keep going up, more structures come into view. You can see the pons. And then as you go up even more, you can see the fourth ventricle here. And then this is very important, the CT angle, cerebral pontine angle system. A lot of tumors actually sit here. So we have to look at this part too quite carefully, because some of the tumors can actually sit here and then cause symptoms, so we have to look at that. Now this is what we call as the transverse sinus. It's part of the dural venous sinuses we have in our brain, which drain the blood back to the jugular vein and then back to your heart. So this sometimes can actually develop thrombosis. So we have to look at this part again. So there are a lot of structures you have to keep in mind when you look at a CT of the head. It's not just looking for the big things, there are also small structures too, which are important. And they also point out, you can also see your globe and you're part of your orbits here. And we pick up a lot of pathology here too in the orbit. Of course, I won't be speaking about that today because that's an entirely different lecture that I have to give on the pathology there. Fine. Okay, here, I think I'm getting some feedback or something is going on. There's some feedback I'm hearing. I hope.
Okay.
I think we're okay now. All right.
Yeah, it's
so,
okay. Fine.
Okay, here you can see this is the fourth ventricle, and they actually found out the structures. The middle cerebellar peduncle, which is the part that actually communicates between the brainstem and the cerebellum. It's the biggest. If you remember your basic anatomy, we have three. We have the superior, middle, and also inferior cerebellar peduncles, and this is the biggest part of that. So you can see that quite well on a CT. Actually, the superior and inferior are kind of hard to see because they are small structures. So, and then here you can see the lens in the globe is pretty well seen, and we can pick up a lot of the pathology here sometimes when we look at brain CTs in trauma and terms of tumor and stuff like that. But I won't be speaking about that today, actually. And here we are coming into the bigger portion of the brain. You can see the inferior part of the temporal lobe here, which is the very bottom of your brain, essentially, which is what we're seeing here. And here's the cerebellum again, and you can see part of your brainstem, and you can see part of the pons in the center, here, right here. And this is your actually the point. I can also have it pointed out is the basal artery, which is what comes together when the two vertebral arteries come together. They actually form the basal artery from the basic anatomy point of view. If you guys can remember it. So here we come into more of the structures. Let me get to this one. This is actually an important structure here, the pituitary gland. There are a whole lot of tumors that can arise there, and sometimes we see them in a CT of the head. Not always. It's not the best place to look for tumors of the pituitary gland, but you can see them if they are big enough. But sometimes the smaller ones, we cannot even see them on a CT, so you have to actually switch over to MRI, which I won't be speaking about today. But this is just a place we have to look to make sure that we don't miss any kind of tumors there. And here again, you see part of the temporal lobe. And then let me get through some more slices here. And this is actually an important structure. They talked about this is a Cantorium Cerebelli, which is the demarcation between the cerebellum and the supratentorial structure, which is the bigger lobe of the brain cortex. And sometimes this is important structure because sometimes when you have a bleed, it can actually layer on top of this structure. So this is actually a fixed structure. So if you have a bleed, that can actually layer on top, and you can see it quite well on the CT. I think there's a case I can also show you. You can actually go to the cases where you can see the bleed. So you have to also look at this structure, make sure it's not thickened, make sure it is in. This is how it should look, very thin and barely perceptible. That's how it should look like when you see a CT here. And here we are coming into a portion of the right occipital lobe. This is extremely important, as you know, the visual cortex sits here. So this is a very important part where you can get strokes. You can develop other kind of pathologies which can actually affect your vision. It can actually cause other symptoms like headache and problems with your other parts of your visual cortex. Essentially can get affected from if you have the pathology there. So let's get through this one a bit. A few more slices here. Okay, this is important here. So here coming into the the midbrain, this portion here we call it as the crus cerebri, or this is actually an important structure that you can find. It actually sits above the pons, and this is called as the interpeduncular fossa. Here just a space that is actually covered by CSF, and then here you can see portion of the right posterior cerebral artery. I mean, these are structures which sometimes show up in our CT, sometimes they're difficult to see depending on the technique. So this is actually, when you do a CT, you have two types of CTs. One is done actually with contrast, one is done without contrast. Most of the screening CTs we do is done without contrast. We don't give any kind of IV contrast. So essentially, what you're looking for in a non-contrast CT is stuff like bleeds, and it's also a quick way to look for anything, any major structural problems in the brain, because giving contrast to a patient has got its own problems in terms of getting, I guess, the patient to have actually a proper IV access and then having to put the contrast in. So we don't always do a contrast enhanced CT in all patients. When the patient comes into the ER or any other location for a screening, we typically only do a non-contrast. So these structures do not light up or show up really well in a non-contrast CT. They actually, so in those cases, if you have any suspicion of something going on there, you need to actually give the patient contrast in a subsequent examination. So we don't typically do this. Actually, this is actually a typical non-contrast CT, which I actually forgot to mention earlier. So that's what we do when we do have screening CTs. We typically only do a non-contrast because it is quick and easy to do, and it does not take time. That's the main thing. So here we are going up again, and you can see this is some of the structures we talk about. These are actually called as part of the basal systems. These are just collections of CSF at the base of the brain, and this you need to look at these quite carefully because there are cases. I'll show you subsequent how these structures play actually an important role to make sure that you can actually pick up the pathology that actually can occur here in terms of bleed, and also in terms of this getting completely effaced in some cases if you have too much of a mass effect, which I'll actually go over in a short while here. So, like I told you before, this is actually ventricular cistern of fossa, which is the same thing here, and they actually are collections of CSF. And let's go through a few more slides here. And here we can see the middle cerebral artery. This is actually an important structure we have to look at, especially in patients who have symptoms of stroke. Sometimes we can pick up a clot or a thrombus in these arteries. Unfortunately, it's not always 100%. In many cases, we can't see it, but in some cases, in cases where we can see it, it's very useful because we can do a very early intervention and then quickly get the patient to do thrombectomies or do other kind of kind of intervention to get the thrombus lysed. And then here we are looking at the cerebral aqueduct. This is the communication between the lateral and third the third and the fourth ventricles. But that's, let me go up a few more slices to get through that part. Hold on, let me get to this. Okay. Here we are going up a bit so that let me get through the ventricular system a bit. Okay, so these are the lateral ventricles. You can see this is actually anterior horn, posterior horn, and then when we go a bit lower, I'm sorry, oh, sorry. Here we're going the other way. Okay, here we are going the other way here just to show you how kind of hard to see the temporal horn in this patient because it's probably a very young patient. They are barely perceptible. Temporal horns typically show a bit inferiorly, but I don't see them, really well here because they're pretty small to see. Okay, hold on. So these are these small structures you can see barely perceptible are the temporal horns here, and in very young people, because the brain tissue hasn't really since it happens to maintain substantial bulk, it's kind of hard to see in this patient the temporal horns, but sometimes if you see them, you can see them actually quite well. And so going through the structure here, okay, this is actually an important slide. So these are the thalamus. You can see there are two of them, and then they're paired. This is the basal ganglia here, Let's get to another. And this, of course, they show you anterior and posterior limb of the internal capsule. Let me get to a few more. And this is the corpus callosum anterior, and this is the splenium. This is the genu, and then here you can see. Let me get to. And this is the falx, which actually separates the two, I guess, hemispheres. There's actually the anterior portion and the posterior portion. And the key part about a CT is you have to look at the midline structures here. Make sure there's no deviation, because that kind of gives you a pretty good indication if there's any kind of mass or the mass effect caused by something in the brain itself, which can push things to one side or the other, and that's kind of important. And here you can see a good a view of the basal ganglia. This is the globus pallidus and the putamen are both part of the basal ganglia. And then here's part of the caudate nucleus, which is here you see anterior. And this kind of wraps around here. And so this is just the head of the caudate, but it's kind of hard to see the rest of the caudate because they're really small structures. And so your CT is not the best way to see them. You have to do actually an MRI, which is an entirely different lecture altogether. So CT is more of a screening tool. It doesn't give you fine anatomical detail. It kind of shows you the bigger structures and look for bigger anatomical changes that you can actually quickly find, and have a quick understanding as to what is going on. So I guess let me just quickly go over the bone windows here, which is what we also use. When we look at a CT, you just don't only look at the brain, you look at the bone too. So these are very good to look at, because especially in case of trauma, for example, you can pick up fractures, which are quite important. There's a case I'll show you down the road today, how it's important to look at the skull and how you can pick up fractures. And you can see, you can actually go through the skull images and quickly screen for any kind of problem. And these are also important here. These are the frontal sinuses you can see. And sometimes we can see also a pathology there, which is more basically benign things like sinusitis and stuff, because you can see fluid within this there's no sinuses, which can sometimes indicate some kind of I guess an acute inflammation there. But so we can get quite a bit of actually of information from just looking at the bone windows. So here, let me go the wrong way here. Okay. So here, let me just give a brief understanding here. These are actually, the mastoids, and these are typically free of any fluid. Any presence of fluid here doesn't necessarily mean that there's something wrong happening, but it gives you some indication that there's probably something that could be wrong. So presence of fluid in this in the mastoid doesn't. Sometimes it's difficult to really say that there's something actually going on, because it may or may not be clinically significant. So some of the things we see on CT doesn't mean that there's actually something, I guess, not happening in terms of actual clinical pathology. And here we take a pretty good look at the inner, at the middle ear here. You can see portion of the stapes, the malleus and tinnitus here, which sometimes is actually helpful to look for when you have issues with your hearing, and that's a different lecture altogether. So we can see a lot of things here in terms of basic information. Let me quickly switch over. So now I am going to present a bunch of cases, which is a good way to learn instead of having to go through this basically anatomy itself. So I'm just going to quickly switch over here to some cases, and then I'll speak about it here actually individually. That way you can understand as to what I'm speaking about in terms of understanding the basic anatomy. So here in this case, we have a person who presents with left hemiplegia. So hemiplegia on the left side. So as you know, the brain is actually, especially the supratentorial brain, is actually crossed So anything that happens on the left side is actually the origin is in the right brain. So we know that there's something that's actually, in this case, that's actually happening is in the right brain. So I'm going to switch over to the imaging portion. Of course, whenever a patient comes in with hemiplegia, immediately we do a CT. We do not wait for actually something else to happen here. So here you can see how you can see. So the key thing here is this structure here. There's a hyperdensity here. I think I spoke to you briefly about that when I was showing you the anatomy part of it. And this is the right middle cerebral artery, and this is hyperdense. And you can see how you cannot see the contralateral side. And this is actually a clot. And this is what we call as the hyperdense artery sign. And this is very, very critical in people who have strokes, because this shows that the artery is actually basically completely blocked by this thrombus. So this patient needs immediate intervention, basically, to get this artery and basically this thrombus lysed. They basically take them to the suite and have infused TPA, which is a drug which actually helps to lyse the thrombus. So this is actually a critical thing to find in a CT of the head. Unfortunately, we don't see this a lot. Unfortunately, in a lot of patients with strokes, it's very difficult to see this sign because it doesn't show up in every single CT. So it's a kind of a not that useful. If it is there, it is great, but unfortunately, you cannot rely on that. So you have to, if you have a very high clinical index of suspicion that there is a patient who has got a stroke, then you need to know, you should not just depend on this alone to make a diagnosis. You have to use tools like MRI to do the problem solving for you. Or if you are really, if the patient is in a really critical shape, they should just go and have they should be taken for straight away neuro intervention, not have to even wait for any kind of imaging to be done because there's no time for that. Yeah. So let me get to another case here. Okay, here, in this case, this patient is a 16-year-old boy hit with on this head with a baseball bat, and or can even be a cricket bat, doesn't matter, it's the same thing, right? Let me go to this one. This is important. So here I can show you why it is important to look at the bone window, and you can see why, because you see this thing here. This is actually a fracture. This is a fracture to the parietal bone, and this here, you see this hyperdensity that I spoke to you about briefly. This is what we call as a epidural hemorrhage. So if you think about spaces in the brain, epidural space is the space that exists between your brain surface and the calvarium. So there is this covering of your brain called the dura mater, which sits right between the calvarium and the brain. And so this is the bleed that occurs right between the two. And this has got a typical shape, which is, we call it as lentiform shape, typical shape. And just from the shape alone, you can tell this is actually an epidural hemorrhage. Why is this critical? This is extremely critical because epidural hemorrhages can get bigger and can cause death very quickly. Typically, these are patients who suffer trauma, and they seem to be okay initially, but then their basically mental status goes down within like an hour or so, and then by then it's just too late to save them because the bleed kind of grows and grows. The reason why this bleed occurs is because when this bone fractures here, there's a structure here called as the middle meningeal artery, and that artery sometimes gets torn, basically gets dissected, and once that the vessel wall gets torn, it starts to pour blood into this epidural space, and then this tends to grow in size without you even having any symptoms, and then by the time you realize it's just too late. So this is extremely important when you have severe trauma that has actually happened. You should probably have yourself scanned just because you don't know whether you have this type of a bleed or not. This is actually very, very critical. So this is a case where, and you need to go and basically, typically in this patient, they need to do a craniotomy, and they need to actually to evacuate the blood if it's actually going inside, because this vessel will actually continue to bleed till you actually stop it. So this is very, very critical that we actually take care of it, right away. So that's why this is important, as you can see here. So this is a case of epidural hemorrhage. Okay, let me get to a different case here. Okay, here is another interesting case. A 53-year-old woman comes with the worst headache of her life. So somebody says they have the worst headache of her life. Where, if you remember your basic teaching, they always talk about one thing, and the one thing is basically subarachnoid hemorrhage, right? So in this case, they show you basically how the basal cisterns we talk about. This is the quadrigeminal cistern, and this is the ambient cistern, this is the suprasellar cistern, and these are all covered with blood. As you can see, they're all hyperdense material here, and you can see it is even going up here, which is this is actually the Sylvian, Sylvian cistern here, and you can see all this is all covered in blood, and some of it is actually going up around the thorax a bit here. So this is actually a subarachnoid hemorrhage. So this typical cause of this is actually a ruptured brain aneurysm. So sometimes we all have these. We have basically sometimes these can stay in your brain very, I guess, quiet, silently, and then they can, I guess, rupture without any warning. So these can actually be almost, I guess, sometimes fatal. And if the patient is actually lucky, they can be brought in, and then we can go and do further imaging and then figure out where it is that they're actually bleeding from. And then we can go and coil them, where we can put like basically a metallic coils and stop the bleed, or we have to basically do a craniotomy and go and actually clip the whole the vessel wall out of the vessel, and then basically seal stop the bleed. So depends on how well the patient does. So some of these patients actually do okay when they come in. Some of them are in really great distress. The biggest danger of a subarachnoid bleed is that of a stroke. So when you have blood pooling around here, as you can see, you have this is actually, if you can see the middle cerebral artery here going through the same area where the bleed is. And so when you have a bleed, the bleed kind of irritates the vessel wall, and that can cause spasming of the vessel itself, of the vessel wall, and that can cause a big stroke. And so that's the cause of death in some of these people, is basically a massive stroke that occurs after the subarachnoid hemorrhage happens. So that's why these are important to treat very quickly. And sometimes you can, this may, I guess in some cases, if you do not do anything, this patient can just die, because you need to stop the bleeding, from going on for too long. So, and this is another case here. Let me go to this imaging. So this is actually a 50-year-old man who has frontal headache and seizures, and you can see that he's got a smoking history. So when you talk about smoking history, you can think about some kind of cancer. So, and so in this case, if you do the imaging, you can see right away. Of course, here in this case, of course, it's actually an MRI. So I will probably not spend too much time here, because as you can see, there's actually a lesion here. And had we done a CT here, you could have just seen a big lesion. Of course, this is actually with contrast. So you could have seen something like this, where you're seeing this lesion, and then you've seen all this stuff around it, which is basically the edema that actually comes with this big lesion. So the guy probably has a tumor somewhere in his lung, and he's got a brain metastasis has actually happened. So these things happen sometimes in, I guess, in an acute setting, or it can happen over a period of time. And let me show you some other cases here. Let me get out this screen and go to a different screen here. Okay, let's see here. So this is, I'm going to show you a bunch of cases here where we discuss ischemia. Okay, so we have here a case, so you can see acute right-sided weakness and headache, right? So if you click on it, let me click on this case here. So here we see in this patient the classic bleed. Okay, so this guy has a massive parenchymal hemorrhage. So this is a huge bleed. As you can see, his blood into his brain. This is all like, hyperdense. I spoke to you about that term briefly. So we use that term. So this is actually a classic how a bleed looks like in the acute phase. So this is actually an acute hemorrhage that you can see. And this hemorrhage is so huge that it is actually tracked into his ventricles. As you can see, this is the lateral ventricle. This is the anterior horn of the lateral ventricle here. And you can see the bleed here. This is the left ventricle. This is the right ventricle. This is the posterior horn here. As you can see, this is the right side. So when you look at a CT, this is the right side, this is the left side. So this is just the way we actually have it presented to us. So you have to just remember it is opposite of how you see it. So you have to be careful that we call the right side as this side and the left side, because sometimes we tend to mix things up. So that's why you've got to be very careful when you dictate your reports, that you have your orientation correct. So this is the right side. As you can see, it's a big bleed, which is actually centered around the basal ganglia, which is here, and also the thalamus, and also a portion of the frontal lobe and the parietal lobe. It's a huge bleed. And then you can see this low lower attenuation in the periphery of this bleed. This is actually the edema that comes with the bleed. So when you have a bleed, it causes actually a pressure on the rest of the brain cells or the brain parenchyma. So that causes the fluid to accumulate between the cells. But that's what is low. You can see this low attenuation around the bleed. So we call this as vasogenic edema, which we see with brain hemorrhages. And you can see all this occurring. And this is what causes the whole midline structure, which is actually the falx. As you can see, this is the falx here in the midline. And see how this has shifted to the right. This thing has shifted, and this has compressed the left lateral, ventricle pretty severely. But it has also done one more thing. It has actually, so here you can see the blood going through from the lateral ventricle to the third ventricle here, and then down to his cerebral aqueduct. And this is your cerebral aqueduct here, and you can see the blood here. It's very hyperdense here, and then going into the fourth ventricle here, and you can see going down into the foramen of Luschka, which is what we call it, foramen of Luschka, and foramen of Megendie down into the into the CFC space of the spinal cord. So this is actually a massive hemorrhage. But the second thing it does is it causes complete distortion of the basal systems. If you remember the CT of the head we saw initially when I showed you the normal anatomy, you saw how we could see the quadrigeminal systems quite well, but in this case they're kind of partially gone. Okay. And then these are the supracellular systems, and then they're completely gone. These are the supracellular systems, they're completely effaced. So in this case, this person is actually having impending brain herniation. So his entire supratentorial structures, that is the structures above the tentorium, is actually going through this, going down below the tentorium. And this can have serious pretty serious implications for the patient's life, because unless they go in and take all this stuff out, and they have to be they have to go in and surgically drain this blood out to take away, to decrease the mass effect, this patient will die. So this is actually a surgical emergency. So this is very, very important. And you can see how this right-sided, the right-sided, the ventricle has become bigger because it has become blocked. The blood, as well as this shifting to the right, has actually blocked this whole ventricle, so causing it to basically dilate compared to the left side. So that is actually kind of critical that they take this patient in right away to get them to surgery. So let me get to another case here. Here is a acute left-sided weakness and neglect in a patient who probably has stroke-like symptoms. So here I want to show you the problem with CT as a screening tool. Sometimes may work, may not work. So here we can, as we scroll through these images, when you look for a stroke, basically, let me go to the basics here. You can see how in a CT you have this high attenuation area here, and then you have this low attenuation finger-like projections. So these finger-like projections are actually what we call as the white matter, right? And then the more higher attenuation here is actually the gray matter. This is actually the brain cortex. And this is the the brain, the white matter, which is the more slightly lower attenuation finger-like projection. So if you have a stroke, or if you have actually an ischemic infarct, you can't see these two structures as clearly as we do here, So if you lose that kind of differentiation, that they know there's a stroke, for sure there has to be actually an ischemic infarct. But sometimes the brain CTs don't give you that information as easily, because sometimes the stroke is in a really early stage. So in a very early stage stroke, you won't even see that kind of that loss of differentiation between the gray and the white matter, as we call it. So sometimes the CT head itself is not going to help you right away tell that there's actually a stroke. So you have to go with your clinical symptoms. So in this case, it says here acute left hemiparesis. So there's got to be something in your right brain from just based on the clinical symptoms. And you can see there's probably something hyperdense here, maybe actually a thrombus, but we don't know that, because you can see even the left side is also the hyperdense here. So is this real or not? We can't be sure. So sometimes we are kind of left in this kind of a limbo in terms of making a clinical, making a clear-cut decision based purely on CT of the head alone. So we have to go and do other types of imaging. In this case, actually, they did actually an MRI, and this is a different, I guess, a lecture, but I'll just show you this thing briefly to show you how this is part of a diffusion-weighted imaging, which we do actually an MRI to look for in ischemic infarct. And as you can clearly see, this entire the right frontal and the parietal lobe and portion temporal lobe are all basically have got higher signal compared to the left side. So this entire portion has actually got an acute ischemic infarct, and you could not see that in the brain CT. And if you go through your brain CT, you can clearly see that you can still see the differentiation between this white matter and the gray matter, which means that this looks like a pretty much a normal, a normal CT of the head. But MRI is a much more sensitive tool than CT. So we can see things in actually an MRI which we cannot see on a CT. So that is a drawback of CT, unfortunately. Sometimes for ischemic infarct, we have limitations on what we can see on CT, especially if it's an early infarct. So it's extremely important that you keep that in mind when you look at a CT. You have to correlate with the patient's symptoms, and that's why we pick up the phone, we call the patient, and and we have to talk to them and ask them how bad are these symptoms. If it's a severe deficit, then you have to say that, well, I don't see anything at this point, but it doesn't mean the patient doesn't have something going on, because CT does not pick those things up in the very early phase of a stroke. So in this case, they have to go to the next level, which is actually to do an MRI, where they can see the stroke, in fact, actually manifest quite well. So here is another case, acute left-sided weakness with right-sided gaze deviation. So when you say the left-sided weakness, you know that it's going to be something in the right brain again. So let me scroll through it and show you what we see here. So in this case, again, it's difficult to make out. You kind of see there's pretty good distinction between the gray and the white matter here. So it's hard to tell whether this patient has got anything going on at this point. And then again, the CT quality is not that great. It is kind of not on such, I mean, not actually such a good quality sometimes. So it's very hard to make out the differentiation as well. But in this case, I don't see any large infarct here if I have to read this CT by itself. But given the fact that he's got pretty severe symptoms, we have to switch over to the next set of we have to go to basically the next level, which is basically we do something called as a CTA, which is basically a CT with contrast. As you can see, this is just a portion of the chest you can see here. So we scroll upwards from the chest up to through the neck into the brain. So I don't want to spend too much time on the neck part of it. So let me quickly get to the brain here and then talk and show you to what we see. So here we are looking at MCA here. This is your middle cerebral artery on the left side, and see how it is fully open, and you can see how you can see the branches of MCA on the left side open. And look at the right side; it's blocked right there. There's no contrast going beyond that point. That's it. So this is actually completely occluded here. So she has got a thrombus here, which is actually completely blocking the right MCA, but you could not pick it up on the CT of the head. And this is one of the drawbacks we have with CT, is that sometimes we cannot pick up early acute ischemic infarct. So we have to go and do other kinds of imaging to figure out as to what is going on in terms of actually an ischemic infarct. Let me get to the next case. So this because again, here we have left hemiparesis, engaged deviation from neglect. So again, let me go through this one. Here again, you can see that it's very difficult. So if it says left, it has to be something on the right side, and you can see that here, even here, it's very hard to pick up any kind of loss of differentiation between the white matter and the gray matter. But then we have to then proceed to the next techniques here to see where the problem lies. And in this case, we actually do something called as a cerebral angiogram, where we actually go physically and we can actually put in the contrast ourselves through a technique through the catheter, and then we can see how this is actually your this is your right MCA or the middle cerebral artery. It's actually blocked right there, and so that's how we find out that there's actually an acute infarct because of actually a thrombus blocking the right MCA here. So this is actually a different way of actually figuring out what is wrong with this patient in terms of actually the cause of its symptoms. Let me go to the next here. One more case, acute symptoms in terms of finding out word difficulties. So here in this case, I would just want to show you this case because I just want to show you how a completed, how an old infarct happens to look like. So this is actually, as you can see, the left frontal and the parietal lobe. This is large area of low attenuation, as you can see, or basically a hypodense area. And this actually shows how an old infarct happens to look like in a patient. So this patient, this is actually dead tissue in a patient who has had a prior infarct, and all this tissue is actually, basically, completely dead. And that's how this shows up on a CT. And you can see here how it also involves part of the basal ganglia as well. So you probably had a prior large stroke involving his left MCA. That's why this entire portion is already dead. So this is actually an old infarct. This is not actually an acute infarct. It's actually something that's already been completed, and this is actually something that's been around for a while. So let me switch out. I think, how much time do I have left? Hello?
So you can, yeah. So you can continue for the next 10 minutes if you want, sir.
Okay, all right. I just want to know
Yeah.
how, okay, hold on. Let me,
Yes, sir.
no problem. So here is actually some cases which we see a lot in PR. It's actually, summertime here, so people drive a lot on their bikes, and we see this a lot. Okay, so I just want to show you this one. This patient, obviously, you can see he had a big accident on the bike, the motorcycle, and this, as you can see, I showed you the same case before. So this is a classic appearance of an epidural hemorrhage, right? This is actually a typical lentiform appearance. I think I showed you that with that kid with the baseball bat. So how do you tell apart? So here you can see how this is a very focal area of hemorrhage. It doesn't spread all down his entire cerebral hemisphere. So it kind of stays in the same area, kind of focal. So this is actually an epidural hemorrhage. And so this patient needs immediate care in terms of surgery. And you can see how he probably has a fracture right there. And you can see how that there's a calvaire fracture in the right parietal bone, and that probably caused actually a direct impact on his middle meningeal artery, which causes this bleed. So here they have to pretty much take the patient in and do surgical evacuation. They have to do a craniectomy, so they have to take portion of the skull out. They will drain out the blood right away, and I can see that this is your drainage catheter that they have put in there, because if you don't do this, the patient will bleed in. And like we saw in the previous cases, when you have too much bleeding here, it's going to push the brain to your left side and cause basically a herniation of the brain down below. And we saw in those cases, if they didn't do this, this will continue to bleed and push the brain to the left side, and then you'll start to herniate and the patient will die. So essentially, this is a surgical emergency. That's why this is a very critical diagnosis to make in the ER when the patient comes in, and you have to make it very quickly. And the patient has to be in surgery within the hour to save his life, pretty much. So this is actually a pretty good case of that. So let's go through this one. This is actually a fall. I'm just showing you this as this case trauma. So here, this is actually a good case to show you the difference between a subdural and an epidural hemorrhage, right? So we saw an epidural hemorrhage before. In this case, we see this very large hyperdense fluid, and it's layering all over the entire left cerebrum. You can see it goes all around it. Okay, so this is a classic appearance of a subdural hemorrhage. And you can see this area of low attenuation here, kind of layering blood here. So this is actually hyperacute blood. This is really, really early hemorrhage that shows up as low attenuation. This is actually called as basically hyperacute hemorrhage. This is actually called as acute hemorrhage. Of course, it's a more technical term that you don't have to really go to. No, I just want to point out, since we have it. And see how the falx is kind of thickened here. See how the posterior falx has to be thin, as in barely perceptible, and see how it is thickened. So the blood actually is tracking along the phalanx. And this is also part of the subdural space that we have here. And you can see how this subdural hemorrhage is actually tracking along this phalanx. And this is actually a classic appearance of a subdural hemorrhage, you know. So epidural or subdural, they do the same thing. They cause actually a mass effect. And how you can see how this entire, the whole midline is shifted to the right side. And if this actually continues to bleed, then eventually you will have herniation. As you can see, in this case, it's already starting to basically herniate a bit. You can see some of the structures of the midline are being pushed to the right, and then you can see this is all distorted, and this should be much more bigger. The paragymnal cistern, and see how it is partially effaced. So this patient is in the process of herniation. You know, this is also a surgical emergency. He needs to go into and have this blood drained out immediately. Or if he starts to basically, once the patient starts to basically have brain herniation, there's no coming back. I mean, you cannot basically reverse the process, because once the brain goes through the process of brain herniation, there's nothing more you can do for the patient. So it's critical that you do this way before this happens. Actually, this is actually, I would say, a bit too late. I don't know, in this case, as to what happened to this patient, but still, this will be a very difficult challenge to save this patient's life, even at this level, where you can see that portions of his basal cisterns are actually partially already gone. So this will be a very tough challenge for somebody to save his life, you know. So this, we see a lot of these patients are on this blood thinners. These days, so many patients are on these blood thinners. This is Coumadin. They have got Plavix, and even a small fall, a very minor trauma can cause these kind of bleeds. I've seen a case of a 90-year-old woman who came in with just a minor fall in her kitchen floor, and they could not stop the bleeding. Of course, the patient died, which is very tragic. But we see quite a few of these cases, of people being on blood thinners, and then they show up with falls. So in this case, we saw this case before, worst headache of your life, and you can see the same exact thing again. You can see how all the basal cisterns are covered with blood. You can see here the suprasellar cistern. This is the ambient cistern, and this is the quadrigeminal cistern here posteriorly. All of them have got basically hyperdense fluid, and this is a classic appearance of subarachnoid hemorrhage. And you can even see the blood going into the sulci. These are the sulci of the brain cortex, and you can see how this basically hyperdensity is actually, it's all over the place. So it must be a brain aneurysm, which must have bled and must have been a really large aneurysm. Sometimes even the smallest of, I have seen even like tiny ones, which are like about 2 or 3 millimeter size aneurysms actually bleed tremendously. So the size and the amount of bleed sometimes have no direct correlation sometimes. So you have to really keep that in mind when you do this kind of CTs. And here is a CTA of the brain, which kind of shows you, this is what we do. Once you see this kind of bleed, you can see this is your big basal artery. This is where the source of the bleed is. This is actually a brain aneurysm which has bled out, and you can see how big it is essentially here. So this is the source of your bleed right there. And sometimes these are actually a pretty big one. Sometimes they can be a lot smaller than this and still bleed a lot out. So there's the size and the amount of bleed have got no correlation actually. So this is actually a pretty good case of that, to show you how we can see this type of cases in there. And here is one more found down unresponsive. So they, in this case, this is actually a pretty good case. Let me show you this one here. So here we can find the same thing. As you can see, this patient has got a pretty significant number of subdural hemorrhage, as you can see here. This is actually hyperdense fluid. Like I happened to point out before, there are some low attenuation areas here, basically hypodense areas here. And this is actually basically hyperacute hemorrhage. So the patient is actually bleeding as he's on the table, on the CT scanner, and he's actually bleeding as this study is being done. That's why it is kind of slightly lower in attenuation or in density compared to this one, which is actually an acute hemorrhage. And it tracks around here the flux, but the biggest portion of the hemorrhage is right here in the parenchyma. So this is in the brain parenchyma. So it probably bled in the brain parenchyma wall, where basically it's in the parietal occipital region, and then it kind of tracked from there into the subdural space. That's what happened in this case. But the question is, what is the source of this bleeding? So you have to do the CTA, like I told you before, we give contrast to the patient, and then that kind of shows you what the exact problem is. Let me get that image here. There you go. So here we do the same thing. We give a patient contrast. We then look and see how the brain shows up after the contrast is given. In this case, you can see these are all these dense structures here are all basically the vascular structures, and this is called as a classic appearance of an AVM or an arterial venous malformation. So this patient has a congenital problem when his brain has developed that he formed a tangle of vessels, which is actually a bunch of what do you call as basically I guess a bunch of vessels which have developed basically abnormally, and these are vessels that tend to not form properly. Okay, the walls are very, very thin. They're very fragile. They form in places where they're not supposed to form, and they can just basically rupture and then cause a huge bleed. That's what happened in this case. Sometimes these are very silent. They can stay quiet for years and years, and then they bleed up pretty much all of a sudden. And we see this sometimes, unfortunately, for the patient, depends on the size of the AVM. In this case, this is a very large AVM, and so the prognosis is extremely poor in this patient. If it's a small AVM and they bleed, we can actually treat them quite easily. But then if this is a pretty significant size AVM, so this will be harder to treat, and of course, he will have a lot of other long-term consequences to this bleed being there in terms of chronic, I guess, deficits in this case. So this is actually a pretty good case of actually an AVM. Okay. So that kind of brings me to the end of what I want to talk about. I hope I've given you some taste of what we see in the ER. And hopefully you guys have learned something from all these cases that I just showed you.
So thank you so much, sir. I mean, this was so interesting. I mean, all of the cases were some of the images were so visually stunning, and we were like relating our first year theory and images. I mean, I did not focus much on the radiologic images in our book, but now, like after your lecture, I mean, it's so amazing. So thank you so much, sir, for sharing your valuable time with us. I mean, so we'll start with the discussions or doubts. So if you guys have any doubts or any problems or any questions regarding this whole beautiful thing, please share it, message it on the DM, or sorry, message it in the chat box, or you can ask sir directly by raising your hand.
Yeah, you can also just go ahead and just, I have to go, let me see. Okay, go ahead, and if you have any questions, go ahead and you can ask me directly. You don't have to put it in the chat box. Okay, I see one question here. It says, sir, if a patient had a stroke of minor aneurysmal hemorrhage and patient is all right later, Do we need to go for surgical treatment? Absolutely, because there's no such thing as a minor aneurysm or hemorrhage, because if you have a brain aneurysm, it has to be fixed. It cannot be left alone. Sometimes aneurysms can bleed and stop, but doesn't mean it's going to go away. Basically, aneurysm is a weakness in the vessel wall that is formed as you develop. So essentially, as you age, these things tend to get bigger and bigger. And sometimes the bigger the aneurysm, the higher the risk of bleed. So it needs to be, if you find one, it needs to be fixed. You cannot let it go. Because even the smallest, like I said, even the smallest of aneurysms can sometimes bleed a lot. So if you find actually that you do have one, it has to be taken care of. You cannot watch and wait because you can't do that. So here is a question. As a undergraduate, can you give a gist on how to approach radioimaging scans? Well, this is a very expansive question. So I don't know what specifically they want to know, but I will say basically from the point of view of seeing a head CT, what we are looking for, like I said, head CT is not a perfect tool. As you saw, some of the cases we can see things that are very obvious, like those bleeds that we saw, but sometimes ischemic infarct is very hard to see sometimes on a CT of the head. So when you look at a CT of the head, you basically are looking for structural abnormalities, anatomic changes that you find. And so the question is a bit expansive. So as far as GIST goes, I chiefly look at I look for something that can kill the patient right away. Okay, those are the things which you should look at in an acute setting. You want to make sure that the patient is not going to die quickly. Like I showed you those cases with those epidural hemorrhages, those subdural hemorrhages. Those things have to be surgical. You got to take care of the patient right away. You cannot wait on this patient, or even the patient with that subarachnoid hemorrhage. So in terms of care, anything with a hemorrhage or a bleed needs to be taken care of right away. Or a patient who has a stroke, for example, even if you don't see anything on a CT of the head, if the symptoms are pretty dense, if you have very dense symptoms of stroke, you need to go and take care of the patient, I guess, immediately. So that is a hard question to answer because it's a very expansive question. So in terms of GIST, how to approach, first you need to basically have a good understanding of the basic anatomy of the structure you're actually looking at. So it's only through that can you really understand when something is actually wrong. So you have to really refer to basically basic anatomy. Even today, after so many years, I go back and I look at pictures all the time when I see these scans, because you need to be very familiar with the basic anatomy of it, and that is kind of critical when you make this kind of diagnosis. So I would say that you are not done with studying basic anatomy after your first year. It is a lifelong process because it's something that you have to keep throughout your whole course of your career, because that's what we all should know quite well. I don't know if I've given you a proper answer for that, but I at least tried.
Thank you so much, sir, for this answer. Yeah, definitely agree. I had to relate everything from my first year, like the anterior cerebral artery that you were mentioning and middle cerebral artery. Yeah, that was so fascinating to again revise in the brain itself. So thank you for that too, sir. So I would like, sir, we have
a
one
question.
more question.
I don't know. There's a question here. I think I just saw both hyperacute and old hemorrhage hypodense on CT. No. Yes, that's a good question. Very good question. Yes, hyperacute blood and old hemorrhage will look hyperdense because I didn't have the chance to show you those cases. Like, for example, when I showed you the case of the subdural hemorrhage, where you had both the hyperacute hemorrhage and the acute hemorrhage, eventually the the acute hemorrhage, as it tends to age, will become lower and lower in density, actually. So it's actually a good point that you made. Yes, the hyperacute hemorrhage and the old hemorrhage can look very similar. So you have to put it in context. I can only call it hyperacute when I see also an acute hemorrhage. You know, you cannot. So you got to see as to what you're looking at. So you got to put it in context and say, well, I see some hyperdense blood. I also see some hypodense blood, but since I see the hyperdense blood, it has got to be it can't be old. It has to be something that's actually new. So you got to put it in context when you do that kind of image interpretation.
So I hope this answers your question. So do we have any more questions?
Any more questions? Anybody? Okay. Thank you for your time. I really appreciate you having me today.
No, sir, thank you so much for your valuable time, for making us understand such images and all, and the scan. So thank you so much, sir. It was a pleasure.
So there is there is a quick question here. I don't know if I have time to answer this one. How do we know there is a tumor underlying a hemorrhage? Very good, very good question. Basically, that is the one I couldn't get to today, because yes, you can have a tumor which can bleed out, and the patient will present as a bleed. So you cannot assume that all types of bleeds is actually because of just a bleed. You can have a tumor which can cause a bleed. That's a really good question, and the answer is yes, there can be tumor within every hemorrhage. So what we typically do is we wait for the bleed to become smaller, or we want to wait for, so once there is actually a surgical evacuation, they take tissue samples and send it to basically pathology to see if there's any kind of tumor, or if the bleed is not big and the patient does not need a surgical intervention, we do either a contrast enhanced CT or a contrast enhanced MRI to see if there is actually something that is that there is a big mass there which actually tends to show contrast enhancement. So that's a really good question. Yes, tumors do bleed, and that can actually present to the ER as basically a big bleed. Yes, absolutely. Okay.
Yeah. Thank you, sir.
All right. Thank you so much. Okay. Yes.
Yeah. Thank you, sir.
No
so the participants are requested to hold on, and QD Center form that you must fill for your mandatory attendance. And so yeah, thank you. Thank you, sir.
All right then. Thank you. Bye-bye.
Bye, sir. Take care.
Thank you. Bye-bye.
Thank you so much, sir. Have a great evening.
Thank you. Thank you so much.
Thank you, sir. I request all the participants to be here for the closing ceremony, and I'll share my screen quick fast. Okay, so guys, excellencies, ladies and gentlemen, which we don't really have any. However, all the medical students here in India and abroad, we have reached the end of our 3-day-long knowledge PAG Neurofest 21 that was conducted by Walter E. Dandy, Neurosurgical Students Club India in sponsorship with Walter Kluwer Publications and All India Book House. And I, Bhavya Pava, the president for Walter E. Dandy Neurosurgical Club India, am here to give the closing remarks on this occasion. it's a sad task, to be honest. Like, I feel really bad because it's been such a great journey. Like right from the beginning of July, when we all started working on that, how to do it, the planning, the people at the back end, the people watching this all over the globe. It's been really sad for me, but because we shall be closing the door on Lively and simulating the debate, as well as bidding farewell to friends and associates. However, it's also a privilege and an honor to be entrusted with such an undertaking at a moment of such eminent people from different parts of the world of neurosurgery and academics. As with all such events, NeuroFest has been an outstanding example. Our minds have been assailed by a torrent of ideas, information, statistics, interpretations, and visions. And it will probably by a day of two before we can shift before them to consolidate our own personal perspective. On behalf of you all, I would finally first like to thank our patron, Dr. Salim Abdul Rauf, for providing us with such a great opportunity and for motivating us to conduct such a large-scale conference, the very first of its kind in a country like India. Thank you so much, sir, for giving at our invaluable time and for always lending a helping hand to Dandy India. This event would not have been possible without the utmost support from you. I would also like to thank our respected jury for the abstract presentation. I would also like to extend a heartfelt thank you to our eminent speakers and panel members for motivating and sharing their wisdom with their neuro enthusiast crowd. And without any doubt has helped to make this event a great success. If everyone is moving forward together, then success takes care of itself. No one can whistle harmony. It takes a whole orchestra to play it. With this, I'd like to thank my most beloved national officers of Dandy India for their never-ending support and hard work. For without them, conducting NeuroFest would have been nearly impossible. Our Vice President, Ojaswini Bali. So guys, as I start, taking out the name of my officers, I'd like them to, turn on their cameras and say a quick hi so that, you see their beautiful faces. Our Vice President, Ojaswini Bali. Ojaswini, do we have you? Never mind. Muskan Chaudhary, General Secretary. Muskan, could you unmute and wave? Okay, I guess their internet is not working or something like that. So I just go ahead now and well, the other officers who helped to make this event a success were our treasurer, Parvati Prem. Parvati, are you here? Our scientific program chair, Ishika Jain. Our global ambassador, Mayank Kalyani. Our IT and social media chairs, Mohit Yadav and Christina Runner. Our public relations and communication chair, Sulekha Intru. And our internal head, Chahek Anand. We greatly appreciate the support we have received from the members of the media in covering our activities. It's very important that, yes. So it's very important that, we actually take a moment to acknowledge the effort that our volunteers for the quiz have also put in, which helped so much all through the time to, help us make this event of the quiz a great success. We're also grateful to all the people from the media to help us. Well, they're too numerous to name individually. Finally, I'd like to thank all the participants and the delegation, without whom the event would have never, ever possible. Certificates of participation and those for the winners are on their way, so get ready for that. Lastly, I'd like to thank our sponsors, Walter Kluwer, All India Book House, for supporting us in this journey. We look forward to working with them again. There's indeed plenty to reflect upon, and if this in any way enhances our individual and collective contribution to the field of neurosurgery and our own personal professional life, then the seminar can truly be adjusted a success if you've enjoyed the week. If you're in the awe of generosity with which we have been treated, inspired by the words of fantastic speakers that have been amazed for us, and enriched by the knowledge that you have gained. That in itself speaks of the success of NeuroFest 2021. As this amazing 3-day event comes to an end, we at Dandy India would like to promise many more such events and engaging and stimulating ones that will hone you to become the successful medical professional you all are destined to become. So keep an eye out on our social media and for further events, and trust me, there's a lot more than this and a lot more where we came from. Until then, Chava Dios, our reviewer. Have a great day, everyone. Hope you all have had the best weekend ahead. See you all again with even better and stronger. Till then, stay safe. See you next year. We take leave from now. NeuroFest Team 2021.